Well, I had a question already that inpatient rehabilitation is for management of morbid obesity. Now, there's a thing that I call obesity immobility syndrome. What I mean by that is if someone becomes big enough, such as the patient that you'll see possibly on Tuesday, eventually they can't walk. And I get many phone calls about people who are over 250 kilograms, and people say, well, what do we do? And I say to them, you have to focus on their mobility. If they can't walk, they can't function. So it's a bit like the opposite. In terms of geriatrics, we talk about immobility, incontinence and dementia. Immobility is one of the obesity symptom complexes that we have to manage. So if someone can't walk, then yes, there has to be inpatient involvement. And you need to get them to be able to walk, etc. The question is, should we be getting people to go into hospital, losing weight quickly and then operating? I don't think so. I think if someone has to be in hospital, yes, you get them into hospital and then you transition them into a well-supported, well-resourced specialist obesity service, so whether it be adult, whether it be teenager, etc. Because we don't offer bariatric surgery to people unless they've had 12 months of assessment and preparation. And what I was talking about before, people eating, in terms of the patients talk about true hunger and head hunger. And what they mean by that is, true hunger is when their belly's rumbling and they're really hungry, and the head hunger, essentially what the word hunger is used a lot for cravings.
Can I just comment on that?
Yes.
Just specifically on that issue, our wonderful clinical nurse consultant does a lot of discussion with families around tummy hungry versus mouth hungry. And it's very interesting because a lot of our families, there's a number of our parents come in and say, but he says he's hungry. And then we work out that the child is very probably using the word to mean, I like that food. I want to taste it in my mouth. And there's a very deep-seated response that many mothers have, parents have, around not allowing a child to go hungry. And yet we use the word hungry to mean, I really like that food and I like to have another serve, please, as opposed to, I am literally without food. I really need some food. And it's interesting in our culture how those have got mixed up.
I agree totally with Louise. And coming from a Mediterranean background, I can say things in terms of a Mediterranean mother, you can never say, if her child says, I'm hungry, it's like an emergency.
And those issues are really interesting, those cultural issues, because there are many different cultures, particularly in Sydney, but throughout Australia. Those cultural issues are really important. So understanding where families come from, their background. We do have in our clinical service at Kids Hospital Westmead quite a high proportion of new migrant families and also families from those very high-risk ethnic groups with this very high prevalence rates. And there is an interesting clash in coming from a culture where there's, in the past, been less food and folk understanding about the importance of having children well fed and being able to, withstand the vicissitudes they're going to come across, and then they meet 21st century Australia with its abundance of food and its sedentary behaviour, and they really clash. I do think will probably take some generations to unlearn those folk understanding about those issues.
And also for people to understand that a child who has excess weight is unhealthy.
Yes.
In their minds, a child who is thin is an emergency. A child who's big, they'll grow out of it.
And also a child who's big can withstand the gastroenteritis, the recurrent respiratory infections, which, of course, they don't encounter as much here. So it is quite different. Helping families to even rethink how they show hospitality and how they show love and care and nurturing is really important. So, many studies, you won't be surprised, showing actually what children really love is time with parents and grandparents, is actually engagement. And of course, they love to have food and so on, but they love that time and they love family time together and, a KO, family times together, and helping families to see that doesn't have to be around a large amount of food. Nevertheless, eating, you'll see when I talked about the healthy, Ate for a Healthy Weight, there's the picture in the middle about doing it as a family. has actually showed people around a table, and actually the Arabic version shows people, is more culturally appropriate sort of picture. But that is around even eating socially is actually a way of actually having a smaller, achieving many of those healthier eating goals. So, being able to talk, slowing down your intake, being able to get feedback signals to your brain occurring. Whereas if you eat on your own, you're likely to eat much more quickly. Sorry.
No, that's
but
true.
yes, if you have a Greek mother, which is wonderful, I have wonderful Greek friends. I love all their mums. But there are interesting cultural challenges.
It's an emergency, Louise. And one of our audience was telling us about in South Africa how the perception is you're healthy if you're big. Did you want to expand on that?
Well, I noticed that the figures were the exact opposite between South Africa and China, in the sense that the young females are fat. In South Africa and throughout Africa, if you're a female and you get married, your father will then get cattle as a bride price, lobola. So women are prized, not males. Women are prized. And if a woman doesn't have a female child, nobody will marry her. But when she's had her first female child, she'll be married. So that's the first thing. The second thing is, for women to be attractive, they have to be fat. The fatter, the better. The Zulu king's favourite wife was known as the Great She-Elephant, and she really did compete with elephants in size. So
I think
socially, nurses are regarded highly. They're all fat in South Africa.
I think we have to be careful, not just, because as you heard with Louise before, I think with patients, we have to say that they have excess weight or they have obesity, not to label them as diabetic or obese. And so I think we have to be careful with our language. But I think what the point you raise and what we're raising is, and I truly believe it's very important for us to understand how our patients feel and think, and how do we make them feel safe enough to be able to tell us what's really going on and how we can support them. I prefer having a support model of care rather than a stick model of care.
It's interesting, Nick. I think one of the issues here is that you do need to understand the culture and the family from which a patient comes. So that's listening to them. And I think one of the benefits of having ongoing treatment and being able to see people on multiple occasions, and I think perhaps primary care has this wonderful opportunity of knowing the context, is that as people come to trust you or the people with whom you work, you start to hear the stories and you get a better understanding at the end. I think people, it's wonderful when people say, I now realise what I was doing before as opposed to now, what I was offering my children now as opposed to now. Or now I feel, I feel far less anxious about coming here than I thought initially would be the case.
That's totally. I mean, the exercise, in the two programs that I run, they have a compulsory on-site supervised exercise program. People get more benefit not from the exercise, they get benefit from the supported group. If you tell a man, and that's why we get 50% men, if you tell a man, as part of our program, we've got a support group, they'll say, Doc, that's a bit airy-fairy for me. But you tell them, we've got an exercise program where we help you. The men love it.
Yeah.
And also, as well as that, as I was saying before, they develop that support. But we also, as Louise said, because they're supervised, my patients are essentially seen 3 times a week. We learn a lot about them during that time. When my exercise physiologist or physiotherapist comes back to the multidisciplinary team meeting and we discuss the patients, we're constantly getting information and we're learning about that individual. So there is, and I'm not saying that everyone needs to, and that's why the patient population that I look after, and as Louise alluded to before, even in the adolescent population, that top of the pyramid that needs that extra level, I call it's the intensive care of outpatient medicine. Not everyone needs to go into intensive care, but there are some people that do. And we need to provide that support and that expertise and the treatment for them.
Is this freely available in every hospital? I mean, I notice that we've all got cancer centres these days at all our hospitals. Do we have this metabolic...
Well, it's interesting that you asked this. We just about 2 months ago, we published, it's called the COSIF project, that talks about clinically severe obesity in public hospitals And in Australia, excluding Western Australia and Northern Territory, which is only about 10% or 15%, there are only 14 specialist, this is in the adult world, there are only 14 specialist clinics in the whole of Australia.
It's incredibly frustrating, and I think it's an example of system stigma, health system stigma and beyond towards people affected by obesity. So we have a really poor availability of publicly funded and adequately resourced multidisciplinary weight management services for people with moderate to severe obesity. That's particularly the case, it's in adults and it's in children and young people, and it's an issue largely internationally, but we see it in Australia and New Zealand, and I think it relates to a lot of stigma. I mean, we have a lot of health managers and senior clinicians who are poorly trained or not trained at all in obesity management. I think many people take on the community attitudes towards people affected by obesity, so they have a negative view towards them. It's a bit like mental health attitudes used to be before. We have patient populations that, in general, have not been allowed to have the voice to advocate for their services, in part because they feel highly stigmatised. And we also have an overwhelmed 21st century health system, and you have essentially a new disease knocking at the door saying, please let me in and resource me. And they're saying, sorry, full up. So there's a whole lot of reasons why this hasn't happened, but Nick and I are here to say it's totally inadequate.
I know, look, and I mean, we were very conservative, and we said there are 1 million adults in Australia who could benefit. If you add up all those spots in these 12 clinics, there are probably 1,000 spots. So that's less than 0.001% of the total population. The other reason, just expanding on what Louise said, is that we're quite happy to treat the downstream effects in terms of pharmacology with diabetes, hypertension, etc. But see, the hospitals are paid for at a state level, and all the medications are paid for at a federal level. So the state doesn't want to do anything. If it was all in one money pot, so to speak, the state would be saying, roll out as many clinics as you can, because it's a lot cheaper to focus on their obesity than it is on all of these other issues.
I'd like to ask you, what percentage of obese people actually get diabetes? I know several people who are not obese and got diabetes,
yes.
And conversely, I know people who are very obese and who do not have diabetes. So you can't actually equate the two. What percentage of obese people
the correlation coefficient isn't 1.0, but it's reasonably high.
I mean, probably the best way to explain it, Ellie, is that in the patients, and the question I usually ask people is that when you developed your diabetes, what was your weight? If they developed their diabetes when they were in the moderate or severely obese category, I can tell you that if they lose 20% of their weight, the vast majority of them will put their diabetes into remission.
Yeah.
But having said that, for example, our patient that we're going to present on Tuesday, or is going to come out, this person who was originally 468 kilograms, he has a normal blood sugar level. He has normal blood pressure. He has normal cholesterol levels. He didn't really have a fatty liver. They talk about that as the metabolically healthy, obese individual. That's about 10% of people with severe obesity who are metabolically healthy. But then they have all these other problems. But the real issue is...
About the other problems.
But about 90% of people with severe obesity.
Diabetes.
But,
think of it this way. Most people are destined to develop diabetes if they live long enough. What happens in this situation is because of their excess weight, essentially they bring it forward by 20 years. That's what Louise was saying. I would rarely see anyone with diabetes in their early 20s when I was training, whereas now it's the majority of people with diabetes.
And most of those people, Ellie, do have overweight or obesity. They do have a high risk family history, so there's genetic priming. If they are people from Asian or Aboriginal Torres Strait Islander background, then they're, and particularly Indian subcontinent background, then particularly relates also to prevalence of central fat distribution, so that if you're Aboriginal Torres Strait Islander or Asian, then your BMI, your diabetes risk starts at a lower BMI than if it's of someone of Northern European background. But there is a strong relationship between obesity and type 2 diabetes.
So what's your percentage then?
Well, in the general population, there's about 10% of people who have diabetes. In people who have severe obesity, it's about 25 or 30%. But what I'm saying is,
so 70% severe people with severe obesity do not get diabetes.
but that's at an age. If you follow them up, they will get it.
So you say that everybody?
No, I'm saying 90%. I'm saying 90% of people who have enough excess weight will eventually develop some problems with their metabolism, and most of that will be diabetes. So there will be 10% of people who won't, but 90% is a huge number.
Ellie, I don't know the exact figures, but when I was in the 1980s, when I was a junior medical officer, there were no children at the Children's Hospital in Sydney that had type 2 diabetes. Now, 10% of the kids with diabetes have type 2 diabetes, and there are a whole lot more, and basically all of them have obesity, and there's a whole lot more of young people entering adulthood, or young adults who have emerging type 2 diabetes, and many of our concerns are about what those implications are for future reproduction, metabolic health, etc.
And it's not, the weight isn't the only factor, but it's the major factor. It's also the quality of what they're eating and drinking, and also the fact they're sedentary. But the major factor that's brought on this diabetic scourge at the moment is really the excess weight. Yes.
Well, two quite basic questions. Firstly, why is a healthy sleep habit conducive to weight loss? And secondly, I keep hearing about visceral fat being of greater significance to subcutaneous fat. How do you measure visceral fat, and does it equate to stomach measurement?
I'll go back. The easiest way to measure visceral fat is waist circumference.
Waist circumference.
Yes.
But you can use MRIs or CAT scans, and that's where some of the original work was done on CAT scans and on CAT scans.
Yeah.
You might know about those, Ernie, and MRIs. And so those were done in the original studies in essentially the late 80s and 90s, where that was actually happening.
The reason I always find it funny, the person that did all this work, his name's Mike Lean, Lean. And the bottom line is, if you're a female and have a waist less than 80 centimetres, you do not have, you're normal. If you have a waist circumference of above 88 centimetres, then you have abdominal obesity, which invariably means visceral fat. And if you're a man, just add 14. So a man with a waist circumference of less than 94 doesn't have a lot of visceral fat. A man with a waist circumference of 102, so 88 plus 14, has abdominal obesity. And sorry, your first question?
Well, a healthy sleep habit was essential for maintaining weight. Is that just gives you more energy during the day? Or?
I think that's part of it. I think it's important. It's not just, if we treated people's sleep, they wouldn't have the 15%, but it is important. And most of the people that I see have significant sleep disordered breathing, whether it be obstructive sleep apnea or even obesity hypoventilation. And yes, they do feel tired. And what we were saying before, as Louise said, for children who say, I'm hungry, which means I like that and I want to eat that. For a lot of adults who say I'm hungry, it can mean I'm tired and I need that energy boost, or I'm thirsty. But hungry is a great word, so it gives it. Yeah.
But there are probably, Eddie, there are a lot of emerging studies. So we know both cross-sectionally that short sleep duration, but also excessively long sleep duration, can be associated with obesity in adults and children and young people.
Mm-hmm.
And there are some work looking at trying to improve sleep duration and seeing if that has an effect on weight. It does have other benefits as well. With many of our young people, adolescents, it's almost, I tell them, it's like their body lives in Sydney, but it's as if their sleep habits are in Perth. So they go to bed later and so on. But we've got to disentangle things like kids who just get so engrossed in screen time, where the families if they don't have rules around regular sleep, they may not be having the rules around screen time, they may not be having the rules around eating breakfast and so on. So a lot of these things are interrelated. often with the kids that I see, we're trying to get the whole family back to what we think is just a basically more healthy lifestyle, where things like food intake can therefore be more regulated and they can have opportunities to be active.
And when you're tired, you're less likely to cook. It's like, oh, I'll go and buy something. I can't be bothered cooking and preparing. So there's a physical activity aspect. There's also the preparation of good, nutritious food, etc.
Another quick one. I think you said BMR reduces with age. I'm assuming this is because of loss of muscle mass. If you exercise and build up your muscle mass, do you maintain a better?
It helps, but it still, it still falls. It still falls. Sorry, there was other questions as well.
Yes, yeah, one last question.
I was going to ask how you both feel about the fad diets that you must hear about from patients all the time, and they come with a paleo diet or an Atkins diet or a 2 days a week starvation diet or a very ultra low calorie diet. Everybody has their favourite way of decreasing calories. Does it matter?
Well, it does matter in the context. When you say diet, I use the word healthy eating plan because someone has to be happy to continue that forever. As I say to them, it's not a course of antibiotics or it's not a course of chemotherapy. It's something that they need to be able to maintain. Now, in terms of, if you think about diets, essentially all they are is in variations of how much fat, how much protein, and how much carbohydrate, and how you're going to change those, and for how long. In terms of starvation diets, the 2-5, our religious organisations have been doing those for thousands of years. So it's nothing new. But in terms of, I think it's important for people to understand, to have a sense of satisfaction, do they need to eat a certain amount of carbohydrate? The protein leverage hypothesis is, as a locus, until you get enough protein, you will keep eating everything until you get to that point. The patient needs to understand what is it that they feel that they need to have so that they don't have that craving for all these extra things. So they keep eating all their rice crackers until they get their protein. Or they keep having, some people need a certain amount of fat, some people need a certain amount of protein, and some people need a certain amount of carbohydrate. And that's the individual aspect of it. But they can't think that I will go on this and then when I stop, everything will be fine.
If I could just comment as well, in our aim for a whole family is to move them, a whole family, to just a basic healthier eating plan for everybody, including dad who may not be at the consultations and extended family. It doesn't matter about their weight status. It's good for everybody. We do use very low energy diets in our adolescents. We will use very low energy diets, so the 800 kilocal ones, initially for over about we give people options, but one of the options is the very low energy diet for a period of time. And we've had done trial studies of those, and we've used those in patients with type 2 diabetes. And I've showed you before how that can actually lead to some remission. But that's supervised, provided by an experienced dietitian, and we've shown improvements in a whole lot of quality of life, etc. measures and eating behaviours measures long term in that context. What we're currently trialling, we've done pilot studies on this, but we're now doing a formal randomised control trial with NHMRC funding as the fast track trial, where we're using not the 2-5, but the 3-4, so 3 days of a very low energy diet and 4 days of healthy eating. What young people told us in our pilot study was that they quite liked the idea of having a sort of free weekend where they weren't on the healthy eating, the absolutely really healthy eating plan. So they had a bit more opportunity on the weekend to not be so controlled because they were out with their mates. But they quite liked the idea of a sort of regular eating plan that included a VLED during the week. So we're trialling that to see if that's something that they prefer, and to look at long-term outcomes. And we've got a 12-month follow-up initially, and we're particularly looking and comparing that with our usual standard healthy eating, higher protein, lower GI diet. So we're wanting to look. That's the first trial in adolescents of alternate day fasting.
Thank you,
Just got
everyone.
one more question.
Oh, okay.
Sorry, I just wanted to ask, how strongly do we have any data? How strong the high screen time is associated with obesity?
Oh yes, screen time and obesity, very strong correlations. We did one of the very first studies. We did the first study in Australia. Very nice, strong correlation in the days when you had TB and not much else. Relation between TB and obesity prevalence. So the first studies were from the US, from Bill Dietz and Steve Gortmaker, from the 1980s, subsequently shown in numerous countries, now being shown in relation to other screens. Of course, screens have become ubiquitous. So they're a force for great good, but they can be a force for evil. And we need to help people think, how do you do that? We spend a lot of time with families thinking about how screen time gets incorporated. Of course, they've got to use them for school, for homework, for, I use them. I go to a clinic I've got, mobile phones and iPads and I've got PCs, you say, whatever you do, don't use a screen. You can't have that approach. But we talk with families about, particularly in terms of that sort of obsessional focused screen time. This is about good general health and well-being, being able to stop screen time prior to going to bed, being able to help families think about charging technology outside of the bedroom, for parents being able to oversee what the children are actually doing when they're on the screens. So you're trying to get just basically good family habits around screens for a whole lot of reasons, one of which is weight status. And then you're helping families to think how they use screens. I mean, as a general paediatrician, I think it's really important that, for example, parents of young children are interacting and talking with them, not on the screen all the time. There's a whole lot of reasons why we want to do that. And we have to help young people navigate that world where it's safe and where they use it well. We have to learn it as adults how to do that well too. But obesity is one of the consequences of excess screen time.
Just because of the sedentary behaviour that
Probably it's probably partly largely sedentary behaviour, but there's also exposure to food marketing, an enormous exposure to food marketing.
Yeah, and I think I might just finish off, Louise. And I think as adults, we have to say to our children, we can't be telling them this is what you need to do. It's not do as I say, do as I do. So I agree with Louise totally that it has to be a whole family approach. Because for every child with excess weight and obesity, there's 1.5 adults who have excess weight and obesity.